I'm going to talk a little bit about what we've done, what we've been doing, and what we are doing to try to improve antibiotic use in the hospital sector. So Lori talked a little bit, or focused her comments on the community side, outpatient settings. I'm going to talk about inpatient settings. Now, I always like to begin by thinking about the end. Where do we want to be? And at the end of the day, we want every patient in every hospital in America to get antibiotics only when they need antibiotics, get them at the right time, at the right dose, for the right duration. And I think it's always helpful to frame any discussion that we have around those fairly simple goals. Now, getting to those goals is obviously complex, but the goals themselves are very simple. The best way to accomplish that, and what's been demonstrated in the literature, is a program within the hospital that's dedicated to helping improve antibiotic use, what we call an antibiotic stewardship program. As Steve told you, when I began doing this, they were called antibiotic management programs. We learned that physicians didn't like to be managed, so now we call them antibiotic stewardship programs. How do we accomplish these goals? Well, as Beth mentioned, we are taking a page out of what we've learned from our efforts and fairly successful efforts to prevent infections that are spread within hospitals. And those efforts have been aided by a number of key factors. We have well-defined interventions with education focused on implementation. We have national measures, so we know where we're making progress and where we're not. We have a national emphasis on solving the problem. We have some national goals to do this. We have policies that spur actions, and we do research to identify gaps in our understanding. And we have taken that and tried to turn this into a national program to improve antibiotic use in hospitals. We recognize that we need better education and training, both on interventions that are effective and much more work on implementing those interventions. We need measurement. That's a big struggle for us inside the walls of hospitals. I'll talk a little about that. We need national goals and policies, which we're beginning to see come to fruition. And of course, we always need research to help us bridge gaps that we identify. One of the big things that hospitals have historically struggled with is how to implement effective antibiotic stewardship programs. And we obviously are dealing with a huge spectrum of hospitals. We have 1,500-bed tertiary academic referral hospitals, but we're also talking about 10-bed rural critical access hospitals. And we think that these programs are equally important in both of those settings, but they certainly don't look the same in both of those settings. And one of the things that we identified as a big gap was guidance for hospitals that would lay out for them how they might implement antibiotic stewardship programs across the varied spectrum of hospitals that exist in this country. And so what we did is look at the literature, talk with experts, and try to pull out from people who had run successful stewardship programs to ask them not who runs your program, what staffing do you need, but ask them what are the infrastructure elements and what are the activity elements that have made your program successful. So not at a staffing level, but at an activity level, how does that work for you? And we talked with a number of these different partners. We looked in the literature, and this is what we found. There were really 7 things that were predictive of success in these different hospitals. They had some sort of a leadership commitment from the very top. The CEO, the chief medical officer of the hospital, they were on board and supportive of improving stewardship, improving antibiotic use. They had one person who was in charge of improving the outcome. So this wasn't something that was diffused to a committee. There was one person who was on point for making this happen. They also had one person in the pharmacy who was critically involved in this effort. Obviously, pharmacists need to be very, very involved with this. We're talking about medication use, and having a pharmacy leader has proven to be critically important. They tracked use in some way. They reported resistance and use information back to the prescribing community. They educated providers about use and resistance, and they were implementing some sort of specific improvement intervention. And those were the core elements that we outlined in this document that we produced, the core elements for hospital antibiotic stewardship programs. One of the big challenges, of course, that we had, and that one of the ones that we've been discussing and that you all are discussing here, is the measurement issue. And this has proven to be a particular challenge in hospital settings. We don't have the type of national data that Lori showed you from the outpatient side. And one of the big challenges is that what we can get access to nationally oftentimes is data on antibiotics that are purchased. Well, in hospitals, they don't purchase antibiotics when they need them necessarily. They might bulk purchase them once a year. And bulk purchasing makes the data look very skewed. It's not information that we can use to get us a sense of what's being prescribed. The other challenge that we have is we want to know what's being given, and that in and of itself is hard enough to establish. But we also want to know why it's being given. It's not just to know how much is being used. We want to know why it's used. As Lori had mentioned to you, it's important to know the diagnoses that are being treated. So that's even harder to get to. And of course, the hardest of all is to know whether, when it's been prescribed, we know why it's given, but was it given appropriately? And that's the hardest of all. And so we are trying to tackle all three of these different measurement challenges in hospitals. The other thing we know is that hospitals really want to be able to benchmark their use against each other to drive improvement. This has been something that's been called for over and over again. This is what the hospital community really wants. We've been doing it for decades for healthcare-associated infections. It's historically proven to be a very, very powerful tool to drive improvements. As Lori mentioned, people in healthcare, and I imagine this is true of people in agriculture as well, we are fiercely competitive. None of us wants to be the worst one. We always want to know how we compare, and that information can be very, very powerful for motivating change. But when you're talking about benchmarking, that gets even more complex, right? Because you have to have some sort of a common definition so that you're measuring like to like. You have to have acceptable risk adjustment for the patient population that's being served to make the comparison meaningful. And you have to have a lot of data in order to draw really strong comparisons. We are approaching measurement in three different ways for hospital antibiotic use at CDC. We recognize that there was not going to be one single thing that would solve all of our measurement challenges, and we're looking at this then in three different ways. We're first of all thinking about these broad assessments of antibiotic use. How do we get a national snapshot of what's going on at a fairly high level? We're thinking about facility-specific assessments of antibiotic use. How do we get information from each individual hospital to help drive their performance? And we're doing that through our National Healthcare Safety Network. I'll say a little more about that, and Beth talked about that a little bit in her comments as well. And we're also focused on trying to get to that gold standard. How do we assess appropriate antibiotic use to know if people are actually using antibiotics at the right time, for the right duration, given for the right reasons? The antibiotic use module of our National Healthcare Safety Network was a module that we launched in 2012. The National Healthcare Safety Network is an electronic system that is currently in place in basically every acute care hospital in the United States. So this infrastructure already exists within all our acute care hospitals. It's a system that's been run by CDC for quite some time. And we added a part to this that would allow hospitals to electronically submit data on antibiotic use. What we collect is what I told you we want to be able to collect, which is the doses that are administered. So this is getting to what's actually been given to the patient per 1,000 patient days. And hospitals can do this for individual locations, and then we aggregate that so that we can look at it at the hospital level. Enrollment is moving slowly, but it is moving. We have more than 100 hospitals that are currently enrolled in this and submitting data. And we're working with those hospitals to try and figure out, looking at their data, what are the factors that contribute to variations in antibiotic use, and how can we begin to benchmark that antibiotic use? We do see the same types of variations that Lori described. If you look at the individual hospital level, we see those same variations, right? So we see 300% variations in the use of broad-spectrum antibiotics on medical wards in hospitals. So we know that there is a huge amount of variation that's out there. The question, of course, is now that we've found that variation, we need to explain why that variation is occurring. The other thing that we're doing is trying to develop a benchmarking measure, and we have developed a proposed measure to try and do that. This is something that's very new for us. This is what we're calling the Standardized Antibiotic Administration Ratio. It is our first attempt to develop a risk-adjusted benchmark for hospital antibiotic use. It expresses observed antibiotic use to what we think would be predicted use for that hospital, given various risk adjustment factors. And Importantly for this measure, we've worked with a lot of experts in antibiotic use and antibiotic stewardship to try and produce a metric that speaks to the antibiotic stewardship community. We want a measure that's actionable. We want something that people can actually use. We don't want to report a measure that only fulfills bureaucratic measurement purposes. We really want this to be data for action. One thing, though, it's some things that are key to note about this measure is that the expected use, the way we're defining that currently, is the average use of similar-looking facilities. So we recognize that expected use is probably still not optimal use. It only tells you that you're using more than other hospitals. Those other hospitals may not be doing a great job either, and in fact, we generally know that most hospitals are not doing a great job. Roughly 30 to 40% of antibiotic prescriptions within hospitals are considered to be either inappropriate or suboptimal. But right now we are comparing the expected use to the average use. The measure is risk adjusted based on facility characteristics. So we have information from hospitals on the teaching status and the number of ICU beds, but right now we don't have enough information to be able to risk adjust that for specific patient characteristics. For example, how many of your patients might be immunosuppressed, which I know we would like to be able to do, but that's obviously a very, very heavy lift and something we'll have to address down the road. This measure is currently being reviewed by the National Quality Forum, but while that measure is under review, we're also turning our attention to trying to measure appropriate antibiotic use. And this is really where we would like to be able to invest some intellectual capital and figure out how to do this. We know this is our ultimate goal. We want to be able to measure whether antibiotics are being used well. And the national strategy that Beth talked about actually does have a goal to reduce inappropriate antibiotic use in hospitals by 20% by 2020. So we obviously need to come up with some way to try and measure appropriate use to know if we're going to be able to make progress towards this goal. We have collaborated with a number of different partners to try and do something like this. We did come up with some assessment tools that we've made available to hospitals that they can use to try and assess appropriate antibiotic use. And the way we've done that is to try and drive this around criteria that are relatively objective. Appropriateness can be very, very difficult to judge, as you all know from your experiences with dealing with sick animals. It's often a judgment call, right, on whether or not a human or an animal needs an antibiotic. There are instances, though, we think where there are some relatively objective criteria, and we've driven a lot of these based on what's recommended in national guidelines. And I'll show you one example, but we try to base these on what we would consider to be best practices for prescribing. This is an example of how we've done that. This is our assessment tool for urinary tract infections. And you can see we're not looking at everything. We're looking at a small number of reasons why we think therapy could be inappropriate. It's not to say that in every one of these instances the therapy is definitively inappropriate, but these are all deviations from what we would consider to be national recommendations. There's generally a recommendation that a urine culture needs to be ordered before you treat a urinary tract infection, and in 16% of cases in a subset of hospitals, there was no evidence that there was any culture that was obtained. In many instances, obviously, you can have a positive culture, but the patient might be colonized and not actually infected. And so in 20% of the instances, 21%, we found that the culture was positive, but the patient had no evidence of having an infection. So we think this represents treating colonization rather than infection, clearly something that we would consider to be inappropriate and an opportunity for improvement. And the last one is the one that's the most puzzling to me. This was, they did get a culture, and it was negative, and the patient had no symptoms, but the chart still says we're giving them antibiotics to treat a urinary tract infection. So, you know, we have tried to come up with these types of things where we could show these to anyone, and I see from the smiles around the room, I think you guys would agree. These are all places where we think improvements can be made. These are areas where people need to go in and figure out, well, what's going on with your prescribing here? What we're really working on now is trying to combine this standardized antibiotic administration ratio, so this aggregate measure of antibiotic use, with these measures of appropriate use, because that's ultimately where we would like to be. We would like to be able to use electronic data sources within hospitals to both measure aggregate use and help people understand how much of that use might represent inappropriate use as an opportunity for improvement. We are also trying to move on the policy front in the hospital setting and in nursing home settings. There are many advisors, including advisors to the President, who have called for the government to mandate or require hospitals to have antibiotic stewardship programs. And the government does have that power. The Center for Medicare and Medicaid Services can mandate actions for hospitals. They have what are known as conditions of participation. And these are basically the ground rules that hospitals have to follow if they want to be paid by the federal government. For example, infection control programs are one of the conditions of participation. So every hospital in America must have an infection control program if it wants to be paid by the federal government. So the government does have the power to do this. We also know that private groups that accredit hospitals are also in an excellent position to drive policy by making some of these types of requirements. And the federal government has begun taking steps in this direction. They've done it first for long-term care facilities. This summer, the Center for Medicare and Medicaid Services did issue a rule that would require nursing homes, long-term care facilities, to implement antibiotic stewardship programs. And we anticipate that they might take this same approach for hospitals as well. So there are actions that are being taken on the regulatory front to begin driving change in this area. But I think what we've learned, my take-homes from the hospital experience, are that it's going to take a multifaceted approach. You can't just have regulations. You can regulate that people have a stewardship program, but if you don't have any guidance for how they implement that stewardship program, how they might make it work, what that program needs to do, then you're really not going to make any progress. So education alone is not going to get us there. Regulation alone is not going to get us there. Measurement is key, but the data has to be actionable. You can't just tell people you're using a lot. You can't just tell people you're using too much. You have to be able to give them something that they can target. You have to tell them where might there be opportunities for improving your use in order to lower it. And I think it goes without saying in many ways that the challenges are really too complex for any group to address this alone. The problems of antibiotic overuse are not going to be fixed by the government. They're not going to be fixed by health systems. They're not going to be fixed by professional organizations and individual providers acting alone. All of these groups have to come together. All the oars have to be pulling in the water in the same direction if we're really going to make the changes that we need to here.